Thank you all for staying for this session. I know it's the last day. We'll be talking about Asian blepharoplasty, and Alice is back, so we can start soon. So our first speaker today will be Dr. Alice Goh. She's from B Specialist Clinic in KL. She's no stranger to us, an expert in cosmetic East Asian blepharoplasty, and she'll be starting off with the topic on mini incision blepharoplasty.
Yeah, I have to stand at the side because most of the time you won't be able to see me behind the podium.
I think there's a stand.
Okay. All right, thank you. Okay, this is better. All right. Okay, thank you. Welcome to this our instruction course on Asian blepharoplasty. All right, so I'm going to kickstart the course with the minimally invasive double eyelid. Okay, so as we all know, in East Asian, when we are lack with a crease, you just tend to appear a little bit more tired, not attentive. So the aim of us to, as a surgeon, is to really create a double eyelid that enhances the patient's appearance while maintaining the facial harmony. And I think it's very important that we create a crease that is very, very natural so that it doesn't look too artificial. So the key thing is to really understand the anatomical features and also to achieve the goal. Right, I'm just going to very quickly go through some of the surface anatomy. I'm not sure if any of the audience here are familiar or are already doing double eyelids, but I'm just going to go through very quickly. So you have this surface, and then you have the upper eyelid, you have the sulcus on the upper part, and this is the medial canthus with the epicanthal fold, and then the lateral canthus. All right, and then some of the terminologies that we probably want to be familiar with. You have the vertical palpebral fissure, the horizontal, and then you have the TPS, which is tarsal platform show. And then you have the marginal reflex distance. You have the MRD1 and MRD2. And then you have the lid brow distance, okay? And next thing, because right now we're in India, we want to really emphasize the differences between the South Asian features, versus an East Asian. So in East Asian patient, we have very unique anatomical differences in terms of the bone, soft tissue, as well as the skin. All right. So in the upper eyelid, the main characteristic feature in the East Asian is a lack of the attachment of the levator aponeurosis is much lower down. All right, and also the orbital septum is attached much lower down that causes the fat to protrude forward. All right. Other features in the East Asian is the presence of epicanthal fold, and then you have this very typical canthal tilt. All right. So eyelid crease, or the double eyelid, is actually a complex interaction between the three vectors, which is the levator, the skin aponeurosis, and also the pre-aponeuric fat. So how the eyelid crease is formed is through the attachment of the levator aponeurosis to the dermis. Like when the levator muscle pulls on the eyelid, it causes an invagination of the eyelid skin along the superior tarsal border, and then this creates a eyelid crease formation. All right, but personally, double eyelid surgery to me is not just creating a crease. All right, it is an intricate work of art. You have to be very meticulous with the attention to details, and then we want to create a natural double eyelid without the telltale sign of surgery. So as if the patients are born with a double eyelid. All right. So East Asian blepharoplasty or double eyelid surgery, to me, it's actually a deceptively simple procedure. Everybody thinks it's simple, but it's actually not that simple. But the principle is actually to surgically create an attachment between the skin, directly or indirectly, to the levator aponeurosis or to the tarsus. But ultimately, we want the crease to mimic a natural crease. So why double eyelid is challenging? Now, because we have two eyes, and the eyelid is a dynamic structure. It comes in a pair, so symmetry becomes a very, very important factor. And the eyelid crease position are also influenced by the surrounding structures. For example, the orbital bone, eyebrow position, which is influenced by the frontalis muscle and also the corrugator muscle. And we see that there are diverse presentation and also anatomy even among East Asian, right? And each patient has each specific expectation. So what patient wants, whenever patient comes to you, so, oh, I just want a beautiful, a natural crease. But what we as a doctor must deal with, before surgery, you have to make sure you assess the type of eyelids, whether it's puffy, how much excess skin, symmetry, proportion. And then during surgery, we have to make sure that we are choosing the correct height, the depth, the dynamic, the symmetry, and we have to deal with the surgical bleeding, swelling, bruising, and of course after surgery it's a recovery, and whether after the recovery, whether the double lid are symmetry, whether it looks natural, and then whether there's scarring, and how about the longevity. So ultimately our aim is actually to create a crease that meets a patient's expectation. So let's go back to basics of how we optimize the outcome. So during the consultation, you really want to talk to the patient and discuss in detail what sort of expectation, all right? And then you want to do a careful pre-op assessment, meticulous pre-surgery planning, and then before surgery, you want to confirm again, make sure that you are really in line with what patient really wants, all right? And then you choose the appropriate surgical technique and also a good post-care. So very quickly, I'll give you some of the simple or important things to look for during the pre-op assessment. For example, patient come with the overall facial asymmetry, with the eye asymmetry, you have to tell patient that it's not possible to achieve perfect symmetry in these sort of cases when they already have a very obvious bony asymmetry and also soft tissue asymmetry. And then some patient may come in with some habitual, brow lift, and that gives them the eyelid asymmetry as well. So you may want to either correct or tell them because of this asymmetry, we may not achieve perfect symmetry. And also some patient may have had toxin injection to the forehead, and that leaves with a bit of asymmetry in the eyebrow, and then you have to address that as well. And of course, you want to make sure that you want to identify any very, very mild ptosis, especially unilateral, because this will also affect the final outcome. So for those who are not familiar how to assess an eyelid ptosis, a lot of patients will present you with hooded, monolid, hooded lid. Some patient thinks that they have ptosis, but not everybody with hooded lid actually have ptosis. So the key thing is to make sure that the excess skin is being lifted out and you expose the eyelid margin. So we want to measure the marginal reflex distance. You want to measure the distance between the corneal reflex to the eyelid margin. So if the margin is actually at a good distance, around 3 to 4 mm, patient is actually okay. They are without ptosis, and you can proceed with the double eyelid surgery. So the other thing is to, like I said, make sure you discuss in details patient's expectation, the eyelid crease, the shape, the contour, whether it's, oh, I only have 2 minutes, yeah? Okay, I'm going to be very, very fast. All right, I will just go straight to the surgical technique. So there are many different techniques. So my colleagues are going to speak about the suture, the full incision. So I'm going to be concentrating on the minimally invasive, which is actually a tiny incisions that you can make. So I have a video here.
2 skin incisions measuring 3 to 5 millimeters are made using blade number 11.
Okay, maybe you can increase the volume a little bit.
Split the orbicularis muscle to avoid bleeding. Now dissect beyond the orbicularis muscle, and small amount of subcutaneous tissues are removed layer by layer to reach the septum. Once the septum is cut, the pre-aponeurosis fat can be removed. The amount of fat to remove depends on each case. Right underneath the fat is the shiny levator aponeurosis. Take a small bite of the aponeurosis and tie to the pre-tarsal orbicularis muscle with a non-absorbable suture, and I like to use nylon 7/0. Here's immediately after in one eyelid. And here's the complete procedures in both eyes. Note the immediate result with minimal swelling. Thank you for watching.
So I have actually shifted, I've done quite a lot of this double eyelid, moving from suture to full incision. But I think in the past 5 years, I have actually resorted to this one simple procedure, which actually to me, able to deliver every possible problem that you may, whether it's puffy lids or hooded lid, you can actually address with this simple procedure. And it's actually very, very quick. It only takes, maybe about 30 minutes. And because of this minimally injury to the lid, patient really, really do have much lesser downtime and a much quicker recovery. So you can see here, there's only 2 tiny incisions, all right, after the surgery, and this is just a week after. So very quickly, the small wound will heal very nicely. Right, you can customize the procedure, how high you want the crease to be. A higher crease, you just measure higher, or you can do a lower crease. All right, even you can address puffy eyelids. But in this kind of patients, I would actually tell them ahead that they may need a bit of touch-up surgery over time, maybe around half a year later, because when it's too puffy, it's not possible for you to remove a lot of fat. So sometimes when the fat is still sitting down, it may causes the suture to loosen, and you may lose the crease. So you would just do it again. All right, it's suitable for men, for women. You can do a unilateral, bilateral. All right, the key thing here, like I said, is to create a dynamic crease so that there's no visible scarring. All right, and so far with this procedure, I've done it since 2001. So the longest so far that I have is a 4-year result, and I think it's still holding on strong, and patients are very, very happy. All right, so in summary, a double eyelid is not just creating a crease, it is an intricate work of art. So you must have a clear understanding of eyelid anatomy, make sure that you do a very detailed patient assessment, manage patient's expectation, do a proper pre-op planning, pay attention to details, learn surgical techniques that you like. All right, MID is a very simple and easy technique to learn, and be meticulous with the surgery, and practice makes perfect. All right, so before I end, I would like to invite you to our ASOPers Masterclass in the Oculofacial Aesthetic that's happening in July 2025 in Singapore. So you can scan this QR code to register. And also, there's another aesthetic meeting in Kuala Lumpur that's happening in August 6 to 7, 2000 this year. All right, with that, I thank you for your attention.
Thank you so much, Alice, for your wonderful talk and your meticulous surgical videos, as always. So it gives me great pleasure to invite the next speaker, Dr. Vanessa Nasim. She's from Penang Island Hospital, Malaysia. She's very active in oculoplastics and a good friend. So thank you, Vanessa. She'll be speaking to us about suture blepharoplasty. I think maybe we can take that away. Height difference.
Sorry, it's okay. Good morning, everyone, and namaste. As to me, the East Asian eyelid is very exotic. As you know, I already have married an East Asian myself. But then again, there's still a very high demand for a lid crease formation among East Asians. So they believe that the lid crease itself makes the eye appear bigger, brighter, and there's a platform to apply makeup. And as Alice has already discussed, so I won't go into the details, but the main aim of the lid crease formation is to create adhesions between the levator and the orbicularis and the dermis. So that is what all lid crease formation surgeries generally aim at. So there are many ways to skin a cat, and there's the mini incision, full incision. Alice has already discussed the mini incision, and there's a full incision, extended blepharoplasty, and the suture techniques. So in this, I'll be talking blepharoplasty with the buried twisted double suture technique. This technique has been described also for entropion correction by Choi and Helen et al. And this technique was described for cosmetic lid crease formation by Kure and Minami. And they did a study over 1,000 over patients, and it gave a durable lid crease. And this portion I've already discussed yesterday, wherein we kind of before the surgery, we discussed with the patient the intended height of the lid crease, and as I told you all, I really like this gadget, this plastic fork-like gadget, which is easily available, which is being sold along with the lid crease forming tapes. The patient also can hold it, or you can hold it with the patient and come at a conclusion as to where you want your lid crease. So the technique is very simple. After the intended lid crease is finalized, we make 3 stab incisions at the point of the lid crease. One is medial, central, and lateral, and local anesthetic is injected. 2 7/0 Prolene sutures are passed in a U-shaped manner transconjunctivally, and they exit out at the skin. So it's normally I use 7-O-Prolin. You can use 6-O-Ethylone also. And so once the two U-shaped sutures come out at the skin, there's this one U-shaped suture and another U-shaped suture which has passed transconjunctively and come out to the skin. There's the two sutures are twisted in the center, and then the medial U-shape goes back under the skin to the medial, and the lateral U-shape needle goes back to the lateral, and the knots are tied and cut. It's a very simple technique. And this is a patient that I did this procedure. You can see the difference in the lid crease. This eye has a lid crease, is nice and big. This eye doesn't have a lid crease. She was actually referred for ptosis, but you can see she does not have a ptosis. It's more of an absence of lid crease, which is making the eye look smaller. So this is a procedure. The eyelid is everted on a silk suture. I did my markings of the intended lid crease, and the 3 points of the 3 stab wounds are marked. One is medial, and generally I go just slightly medial to the medial pupillary border, then one in the center and one lateral at the lateral limbus. The eyelid is everted, local anesthetic is injected, and the eyelid is pulled on a lid guard, and I make the 3 stab incisions. Normally I make the incisions quite deep because I want to induce a scarring. So first is the lateral, then is the central, and then is the medial stab wound. And once the 3 stab wounds are made, I do further dissection to create a pocket, and also the dissection creates a pocket for me to bury my knots, and also it induces a bit of scarring which gives rise to a more permanent lid crease which lasts for very long time. So now I'm creating the pockets for me to bury my knots and to induce a little bit of scarring. If you want, you can also excise some orbicularis if you wish to do so, but I don't generally find the need to excise orbicularis. And you can also excise fat if you want, but I don't generally do. So this lady has, as you can see, she has quite puffy eyelids. So now I'm passing my first double arm 7-O-Prolin that goes through the conjunctiva and then comes out through the lateral stab wound. This is the, comes out through the central stab wound, and then the second needle of the double arm passes through the conjunctiva, grazes the tarsal plate and comes out through the lateral stab wound. So this is the first U that I'm forming, and then same again medially passes through the conjunctiva, and then the needle grazes the tarsal plate and comes out through the central stab wound, and again passes through the conjunctiva and comes out through the medial stab wound. So now I have 2 double arm 7-O-Prolins on the skin. The central part is where the twisting is done. The central sutures, they are twisted among themselves. You can twist about 4 to 5 times, and once you have twisted about 4 to 5 times, the needle passes subcutaneously, and then the needle that belongs to the lateral U goes to the lateral stab wound, and the needle that belongs to the medial U goes back to the medial stab wound. And I'm turning to make sure the sutures are not exposed, and the knots are tied and cut. So now it goes subcutaneously and comes out through the lateral stab wound, and the needle that belongs to the medial U after twisting passes subcutaneously and comes out through the medial stab wound. And the knots are tied and cut. So this lid crease formation can be done in any patients. It not necessarily have to be East Asian. Any patients wherein you want a lid crease, you can, and if they don't have a lid crease or there's some asymmetry, you can perform this procedure. And so this is the same patient after the procedure. You can see she's got quite a nice lid crease. Even though she's eyelids are puffy, you don't need to do a full surgery. And when you do this kind of minimally invasive surgery, the healing is also faster, and the patient tends to recover fast, and they're generally quite happy with the outcome. This is the same patient before and after. You can see she's got a nice lid crease. And with that, I'd like to thank you all for your kind attention. I'm extremely happy to come in this beautiful city and imbibe in its culture, meet my fellow friends, and learn from all of you. Thank you so much.
Thank you so much, Vanessa, for sharing your DST suture blepharoplasty technique with us. Next, I'd like to invite Dr. Min-Jung Lee. She's from Halen Medical Center in Seoul, South Korea. She's also very active in AP-Suppress, and she'll be speaking to us about full incision blepharoplasty. Thank you, Min-Jung.
Good morning, everyone. I'm Min-Jung Lee from Korea, and I'm very happy to be part of this wonderful course together with outstanding colleagues. And the title of my talk today is Full Incisional Blepharoplasty. Let me start with a very fundamental question. What are the goals of upper blepharoplasty in Asian? Most patients want to make a lid crease and have larger and more open appearance, and they also want to reduce eyelid heaviness, puffiness, and fatigue. And if they have some asymmetry, they want it corrected. To achieve these goals, we should know well about the characteristics of Asian eyelids. Here are typical cases from my clinic, and skin hooding, puffy eyelid, mild ptosis are very common, and many patients had no eyelid crease but have thick eyelid skin and hypertrophic orbicularis muscle. And all these characteristics are challenges for successful blepharoplasty. So I believe full incisional blepharoplasty is the optimal procedure that can manage these all problems at once, like superheroes. So there are 4 steps of full incisional blepharoplasty. I will demonstrate one by one. The first is skin marking, and accurate design is essential to make a natural and symmetric eyelid crease. Lower line is typically drawn at 5 to 7 millimeter from the lid margin in males and 6 to 8 millimeter in females. And and for the upper line, the height is measured according to the redundant skin, and we should keep in mind that the pre-tarsal show is the actual visible height of double eyelid. So the ideal pre-tarsal show may vary by races, but 2 or 3 millimeter in East Asian. And the amount of skin excision can be measured by either supine method or sitting method. I use both, but I prefer sitting method when the patient have very severe dermatocollisis like this, or the patient has any brow problem. And the second is management of burden factors. And burden factor can be defined as any condition that limits the eyelid movement. And the burden factors include thick skin and hypertrophic orbicularis muscle and submuscular fiber adipose tissue and thick septum and lower portion transverse ligament, orbital fat, and lacrimal gland. And during the blepharoplasty procedure, you may encounter submuscular fiber adipose tissue, thick septum, and lower portion transverse ligament like this, and orbital fat. And I will show a short video about the management of burden factors. And the orbital septum was opened. You can see it is very thick and multi-layered. So I proceeded the dissection until I can clearly see the preoperative fat. And the preoperative fat was excised to reduce the puffiness. And you can see here a remnant septum, and I trimmed it. And I checked the liberator power, and a small piece of pretarsal orbicularis muscle was excised. Here is a 41-year-old male who complained of lid drooping and forehead fatigue. You can see he has very puffy eyelid, and there are some lines here. And intraoperatively, there was very prominent lower portion transverse ligament here. It corresponded to these lines. And so I did blepharoplasty with cutting of low Persian transfer ligament, and you can see the puffiness was really well corrected with well-formed crease. And also, lacrimal gland prolapse can be a burden factor. Here is a case, 25-year-old female who complained of recurrent loosening of the temporal crease and palpable mass, even after several times of blepharoplasty. Here you can see a little bit partially loosening of the crease and abnormal fold, and CT scans showed a little bit prolapsed lacrimal gland without any enlargement or enhancement. So I repositioned the lacrimal gland and placed a few lid crease formation sutures. So postoperatively, the abnormal fold was disappeared and the crease was well formed. And lacrimal gland prolapse can be corrected by periosteal fixation of the orbital lobe using matrix sutures like this. I usually use double-armed fiber vicryl. And the third is ptosis. So ptosis should be corrected to achieve a well-defined crease. And there are three key preconditions of eyelid crease formation. The first is adhesion between posterior and anterior lamella, and the second is smooth gliding zone to make such fold, and the third is contracting pole of the levator. This 47-year-old female visited me with persistent eyelid drooping even after blepharoplasty. Very surprisingly, many patients think blepharoplasty and ptosis surgery are the same. So I explained you need blepharoplasty, not blepharoplasty, but ptosis surgery. So I did levator resection, and here is the results. And the last one I want to talk about is techniques of lid crease formation. There are many fixation methods to make lid crease, and I will show a few. And this is levator fixation technique, which is my preferred technique. And I use this technique for the patient with good levator function. And when I want to make a crease 6 millimeter or higher, and I use the 7/0 nylon, and I place usually 5 or 6 sutures. And also you can make a crease with skin levator skin sutures. It is very simple technique, and you can also close the skin simultaneously. And I use this technique when the patient has very thin eyelid or additively to other techniques. And this is Tau technique, and Tau means tarsus levator orbicularis, and I use this technique when I want to make very firm eyelid crease or revision cases. It involves both tarsus and levator, so you can make very stable and strong eyelid crease. The fixation height is very important, and the isotangent fixation would be make very natural eyelid crease, but high tangent fixation would make deep and puffy fold, and it would cause eversion of the eyelash and even ectropion. And too low tangent fixation would be undesirable too. So I think the key is balance, and the beauty of moderation is essential to every step of blepharoplasty. So in summary, full incisional blepharoplasty is really straightforward and effective procedure for most patients. And the skin marking and design are crucial and important first step for a successful outcome. And managing burden factors is essential for not only make crease, but also to make ideal eyelid shape and volume. And if the patient had ptosis, it should be corrected. And surgeons should be familiar with various lid crease formation techniques. And most importantly, each procedure should be individualized, tailored to the patient's unique characteristics and preference. Thank you for your attention.
Thank you so much, Minjang, for beautifully showing us how you deal with all the burden factors of the East Asian eyelid. So next, we'll have a bit of a change. It'll be Prof. Kyung In Wook. Dr. Kasturi will go later. So Prof is my mentor from Samsung Medical Center. She's really the expert in East Asian blepharoplasty. So she'll be talking to us about epicantoplasty and its usefulness in Asian blepharoplasty. So thank you, Prof.
Thank you for a kind introduction. I'd like to talk about the epicantoplasty and its usefulness in Asian blepharoplasty. Epicanthal fold can be categorized: no fold, epicanthus tarsalis, epicanthus palpebralis, and epicanthus inversus. Let's look at the effect of epicantoplasty. Epicantoplasty can relieve the vertical tension in double eyelid surgery, change in configuration of eyelid crease, change in the inter-epicanthal distance, and leave scar at the medial canthus in varying degrees. Inter-epicanthal distance can represent ethnic characteristics. This 15-year-old patient underwent epicantoplasty for pseudoesotropia after strabismus surgery. The procedure can shorten the inter-epicanthal distance, showing more opened look. This 17-year-old patient underwent levator resection without crease formation and epicantoplasty. The shortened intercanthal distance shows more open look. This 19-year-old patient underwent levator resection and epicantoplasty. The procedure results in an in-fold type, a small double-eyelid crease with shortened inter-epicanthal distance. This 19-year-old patient underwent levator resection and epicantoplasty. The procedure results in in-fold type, small double-eyelid crease with shortened inter-epicanthal distance. This 22-year-old patient underwent levator resection and epicantoplasty. The procedure resulted in in-fold type, small double-eyelid crease with shortening of inter-epicanthal distance. This 17-year-old patient underwent levator resection and epicantoplasty. The procedure results in outfold type double-eyelid crease with shortened inter-epicanthal distance. So you can notice the shape of epicanthus, medial canthus after the epicantoplasty. The complete opening of the epicanthus can make the outfold type of double-eyelid crease. This 21-year-old patient underwent levator resection and epicantoplasty. The procedure results in on-fold type double-eyelid crease, shortened inter-epicanthal distance. This 24-year-old patient wanted to have a high definite crease. She underwent levator resection and epicantoplasty. The procedure results in on-fold type double-eyelid crease and with shortened inter-epicanthal distance. This 21-year-old patient results in on-fold type double-eyelid crease with shortening of the inter-epicanthal distance after levator resection and epicantoplasty. This 19-year-old patient presented with poor levator resection, poor levator function with severe epicanthal fold in the left side. She underwent levator resection and epicantoplasty to get a symmetrical outcome with left-sided surgery. This 23-year-old patient presented with unilateral ptosis and epicanthal fold. He wanted unilateral levator surgery without epicantoplasty. So the result is symmetrical, and it does not, in this kind of patient, we don't need to have epicantoplasty. Various techniques of epicantoplasty have been performed. Current method can be categorized to advancement of the flap technique, transpositional flap technique represented by Park Z-plasty and Root Z epicantoplasty, and skin excision method. In the analysis of 48 articles on the epicantoplasty, Z-plasty was written most frequently, followed by advancement technique. The Z-plasty was the most frequent and still increasingly cited. Excision has decreased and no more articles have recently been written. Advancement has continuously increased but has stabilized after 2010. Nowadays, skin redraping epicantoplasty is frequently performed in South Korea. I'd like to talk on skin redraping and root Z epicantoplasty. Here's root Z epicantoplasty. This technique adopts similar configuration of G-plasty. However, the size of the flap is half of it. The incision height is limited in very thin skin. You can see a softening effect of the epicanthal fold in the post-op picture. This is a procedure of root Z epicantoplasty. First, make a mark on the surface representation of the medialmost point of the lacrimal lake. Secondly, draw a horizontal line to the epicanthal fold. Thirdly, connect the line to the point where the fold blends with the lower eyelid skin. Fourthly, connect another line to the medialmost lacrimal lake. And two flaps are dissected from the bed. A thick fibromuscular band is identified and resected to soften the epicanthal fold. The transposed flaps are sutured with 7/0 nylon. Some excessive flap is trimmed to fit the defect. A 25-year-old female patient underwent levator resection and double eyelid crease and root Z epicantoplasty. On-fold type double eyelid crease is formed. This is wound healing process of the root Z epicantoplasty. At 4 months after surgery, you can hardly see the scar at the medial canthus. This is a skin redraping method. The depth of epicanthal fold is measured with a pull and release technique. If you pull the medial skin medially, then you can find the medialmost point of the lacrimal lake, and then put the pencil on the site and then release the medial skin, then you can mark the deepest portion of lacrimal lake onto the skin. The depth of epicanthus in this particular patient is 2 millimeter. From that point, a horizontal line is drawn to the medialmost lacrimal lake and extended to a point below the punctum. After skin incision, skin flap is raised from a dense medial canthal attachment. After the dense tissue is excised and the flap attachment is released, medial canthal suture is placed with 7/0 nylon. Lower skin flap is redraped medially and closed with interrupted sutures. A 24-year-old female patient underwent levator resection with double eyelid crease formation with redraping epicantoplasty. On-fold type double eyelid crease is made without any vertical scar at the medial canthus. So in summary, doing the epicantoplasty, select a procedure which is familiar to a surgeon, leaving less scar, and use a natural skin crease line for double eyelid crease designing, and medial configuration of double eyelid crease may be dependent on the degree of epicanthus and height of double eyelid crease. Thank you for your kind attention.
Thank you so much, Prof. Wu, for that excellent and instructive lecture on epicantoplasty. So from the immediate past president of AP Sopres, we now have the president current of AP Sopres, Dr. Kasturi, who will be speaking to us about extended blepharoplasty.
Thank you, Dr. Stefani, for having me in this course. I think the blepharoplasty today is the most common surgical procedure, and that is what I see most of my colleagues putting in Insta, in Facebook, in Thread, and also in the podcast. And today we are here to discuss extensively about blepharoplasty, and I've been asked to speak on extended blepharoplasty, where I'll be covering more of the upper lid and a little touch in the lower lid. So when we call about the upper lid blepharoplasty, it is a surgical procedure where variable amount of the eyelid skin, muscle and the fat are either excised, re-draped or sculpted in order to give a very rejuvenated look. And this has come from the word blepharon. Sorry, I've been talking since 2-3 sessions since morning. And then today it is the most time-tested surgery having both functional and cosmetic indication. So when we call upon the upper lid blepharoplasty, there are different types. It can be a mini blepharoplasty, mini by Dr. Ellis, then we have standard, we have muscle excision, we have extended, we have only skin excision blepharoplasty, and a fat repositioning or transferring upper blepharoplasty. And all these blepharoplasties are on the basis of the skin incision, skin excision, skin, muscle and fat excision, and fat transpositioning, and I'll be talking basically on extended blepharoplasty. So which are the conditions where we need to do an extended blepharoplasty? Condition like this, where you have so much of lateral hooding, where you have so much of fat being prolapsed, where you have so much of skin being affected, thickened skin, and the most important, when you feel that it's basically a functional indication where there is a decrease in the temporal field of vision, as we have already reported, and not only that, there is also which affects the contrast sensitivity and the high order aberration, as we have already reported. These are the situation where we really need to do an extended blepharoplasty. This is not a cosmetic indication, this is basically a functional indication where you need to excise variable amount of the skin, muscle, inside the orbital septum, remove some of the fat, along with it you need to remove the roof. So once you remove this retroorbicularis oculi fat, you need to refix the eyebrow to a normal position, otherwise you will not be addressing the lateral hooding. And this is the standard way of refixation of the lateral hooding, or the refixation which we call the internal bropexy. This is which all of us are being doing, and this gives a very good lift along with the lateral lift suture, where many people also call it as a brassiere suture. So this is how we do in an extended blepharoplasty. And the main indication here is functional, where you need to address the lateral hood, you need to address this excess amount of the fat, the excess amount of the skin, in order to give them both a cosmetic and a functional correction. But what I want to mention is there is something, another extensive upper blepharoplasty, which is again a functional indication in apraxia of eyelid opening. In apraxia of eyelid opening, the main pathology is the silencing of the LPS along with the involuntary contracture of the orbicularis. So you need to remove the rheolin muscle, you need to remove some amount of the pretarsal, keeping a strip of the pretarsal, and maximum amount of orbicularis along with the other protractors of the eyelid. So when I say of the protractors of the eyelid, this includes the orbicularis, this includes the procerus, it includes the corrugator. Orbicularis you need to remove right up to the fronto-orbicularis interjunction, and when you remove the corrugator you should be very careful, because just below the corrugator you have a very important structure. This is the superior ophthalmic vein. So this is how you need to remove most of the protractor group of muscle in both the upper and the lower lid, as you can see here, and this is really extended blepharoplasty having a functional indication, and these people really feel very happy because the spasm decreases, the quality of life decreases. Like this is the lady who says that she feels that she is now a new woman, and actually this really gives a very good relief. But when I was mentioning that when we do extended blepharoplasty, we need to take care of the lateral hooding. So this is a new technique which I call the 4-point guiding suture and fixation, and this is how we do for scleral fixated IOL. So this is how you need to pass a lipocannula and slowly guide it below the periosteum and give a very good 4-point fixation, and I have been doing this for the last 3 years. I feel the results are much better when we do an internal bropexy with this technique, where I find that it is quite better, giving a very good lateral lifting, and also the results are, at least in my last 3 years follow-up, I could see it's a better technique than the standard procedure. Another extended blepharoplasty in case of blepharochalasis, where there is a prolapse of the lacrimal gland. So here, we remove the skin only, we do not remove the muscle, we do not remove the fat, but what we need to do, we need to reposition the lacrimal gland, that you can see here. Once I incise the orbital septum, this is a lacrimal gland which you need to refix. Again, refixation is what I want to say. Many of us, even I was using Prolene suture, but what I have realized in my practice, that Prolene is basically a cutting suture. So I like to use something, multifilament, the Polydec, which I feel is better because it does not cut through the periosteum in many of the situation. So this is how she looks post-operatively, and when you compare her pre and post, it gives a much better correction, and this is also a type of extended upper lid blepharoplasty. So in lower lid blepharoplasty, same thing, where the variable amount of fat, muscle and the skin are either being excised, it is being transposed, sculpted or transposed in order to give a very rejuvenated look. So this is a standard lower lid blepharoplasty, where what we do, we try to make the 3 fat pedicles, and this fat pedicle needs to transpose as down as possible. When we talk about socket reconstruction, we always say that the donor and the recipient fat should be in touch so that the flap stays viable. Exactly from my practice, what I have learned, if this flap we can transpose deep down to the DMCF, that is deep medial cheek fat, then it stays more viable. So releasing the orbitomalar ligament, we need to do a transpositioning of all the 3 fats, and it gives a very good correction. But if you really look nicely, what it is correcting the periocular region. But being an oculoplastic surgeon, facial plastic surgeon, it is not correcting the mid face, and we need to consider the eye, the whole face as a unit, upper, mid and the lower. So what I have decided, what I am doing now, so along with a lower lid blepharoplasty, I am doing little more extensive surgery, that is a mid facelift. Like look at here, this is the right side not operated. You can see the nasolabial fold prominent, and this is just after the surgery, where what you do a standard transconch blepharoplasty, then you come outside and remove some of the strip of the skin, and you expose this mass and lift this mass, and this mass will lift the face. And on the table you will see the difference. This is how I really do a small pinch test, and then you excise a very little amount of the skin, and then you expose the mass. This is the instrument which all of us use for the facelift surgery. Go as down as possible, and then you fix this mass to the deep temporalis fascia, and you can see, if you really look here, oh my god. This is now, you can see this nasolabial fold is not seen, and on the table you see a correction. This lady had a very heavy face, and it gives a much better look, as you can see, very early post-op, before and after the procedure. But I have realized that a vertical facelift is a much better choice, which we call a centrofacial facelift. So along with this, along with the lower lid blepharoplasty, is a very small extended procedure, I should say, where you need to form 2 vectors. One vector is to pull up the mid face, which also pulls up the lower face, and other vector which I am drawing is order to transpositioning of the orbital fat. So this is basically a transcutaneous approach, where you expose all the 3 fat pads, the medial, central and the lateral. I usually excise some amount of the central and also the some amount of almost whole of the lateral, and then you keep the medial fat pad, come back and go for the mid facelift. You need to separate in layers, go as down as possible, go up to the canine tooth, level of the canine tooth, and once you separate, you can pull it up in 2 vectors. One is a deeper tissue including the periosteum, and other is the smash. You expose the deep temporalis fascia, which is a whitish layer just below the superficial temporalis fascia, and these are the 2 vectors for the suture. And on the table, so you can see, you can do such a, can you see? You can, the whole of the face, you can pull it up. You can use a 2 Prolene, or you can also use a Polydec suture. And once you are done with the facelift part, the mid face lift part, you complete the lower lid blepharoplasty, go for the transpositioning as down as possible, and this completes the surgery. And this is how she was before the surgery. If you look the NLF, look here, and when you look to, even in a, there's some amount of swelling, but she looks much better, and you can see that what we are treating the whole face as a unit. Though I have done only up to here, you can see even the lower part has also been lifted. And time is over. And sometimes I'm going fast. Along with it, you need to do a facelift, especially this paralytic patient. So I feel that blepharoplasty is a transformative procedure that addresses the aesthetic concerns of the eyelids. We need to select the appropriate procedure. And with this, I would like to thank again Dr. Stephanie for this wonderful session and for having me here. Thank you very much for your patient hearing.
Thank you so much, Dr. Kasturi, for that wonderful lecture on upper and lower extended blepharoplasty. Every time she gives that lecture, she's always teaching us something new, so thank you. So we've come to the last part of today's session on Asian blepharoplasty. It'll be on complications and its management. So just now in Dr. Tajani's IC, I talked about more the functional complications like hemorrhage, lid retraction, and so on. Now we'll talk more about the nuances related to Asian blepharoplasty. Well, while we're waiting, are there any questions you want to ask the previous speakers? I think it's very nice how we started with mini incision, and then suture, and then full incision, and then extended, and then epicantoplasty. I think every speaker really showed the pros and cons of each technique. It's hard to say which is better, and I think it really depends on what works in your hands. I just want to ask Vanessa, so for the suture blepharoplasty, I mean, it's really nice, but how long does it actually last? What's the longest it's lasted? Because my plastic surgeon does a lot of the DST that you showed, and when I ask him, he always says, well, maybe 4 years to 5 years max. What's your experience? Oh, okay, now my answer, yeah, you can answer first.
It does last for a few years, perhaps not a permanent thing, and if it fades off, you can always just redo it. Maybe not as permanent as surgical technique, but it is something to consider because the healing is very fast and the complication rates are very low.
Yeah.
Anything
Yeah,
else?
the young people like it. They like the fact that it's very fast recovery. Yeah, and actually they like that it might be reversible as well. Yes.
My question is to Vanessa. The suture part is exposed in the eye. So do you have ever this is just hitting the epithelium of eye when we are rolling? No.
And maybe you can speak into the mic. So.
And when you show your technique, how do you undermine this? Because you are going transconjunctivally.
Okay, later we'll do that in the Q&A. We'll finish this lecture first. Yeah. All right, thank you. So we've come to the last talk on Asian blepharoplasty complications and management. These are my disclosures, none of which are relevant to this talk. So actually, you can find most of it in this paper that I've written with Prof. Kim Yoon-dak in facial plastic surgery. You can also find it in IFAS. As you know, it's a very famous International Fellowship in Advanced Aesthetic Science, and that's the website above. But basically, just a background, I think all the speakers have emphasized the East Asian upper eyelid is different. It's characterized by a low, absent, or variable superior palpebral crease, a fuller lid, and a medial apicanthal fold. So double eyelid surgery, or Asian blepharoplasty, or if you want to correctly term it like Alice has published, it's East Asian blepharoplasty, is one of the most popular aesthetic surgeries among people of East Asian descent, whether it's Chinese, Korean, or Japanese. And the premise really is to surgically create that supratarsal crease to achieve a more aesthetically pleasing eyelid, and it's performed by incurring the dermis to the tarsus or the levator. So I think complications do happen. Patient expectations for cosmetic surgery, so Asian blepharoplasty is a cosmetic surgery, is often very high. The problems may arise even in the hands of the most careful surgeon, And I think the complications can be categorized. Number one, subjective complaints due to patient dissatisfaction with results. Number two, problems with the eyelid crease, whether it's asymmetrical, too high, too low, multiple, or they disappear with time. Number three, problems with eyelid height, whether it's ptosis or lid retraction. Number four, suture-related complications, especially from the Barrett suture technique that passes through the tarsus. Number five, complications related to eyelid surgery in general. So I think patient dissatisfaction has a few factors. There is evolution of Asian beauty. I think the perception of beauty and attractiveness is one of varying likes and pleasures. There's significant developments in the idealized periorbital appearance of the Asian patient since double eyelid was introduced at the end of the 19th century. So in the 1980s, westernization was highly popular. However, today the watchword is cultural and ethnic preservation, which can subtly but dramatically enhance the appearance of an individual. So I think very important, if you're going to be doing a lot of Asian blepharoplasty, you have to spend a lot of time on pre-op counseling. It's a two-way process. The surgeon needs to precisely understand all the patient's wishes, and the patients need to understand what's realistically achievable from surgery, and what that healing process varies between individuals, and the surgeon should try to convey this message to the patient. So moving on to eyelid crease abnormalities, I think it can be classified by the depth of the fold. It can be too shallow or too deep. The crease height can be too high, too low or too high. Pre-tarsal fullness, too full, too hollow. Increased number, no crease or multiple creases. So let's talk about depth of fold. If it's too shallow, it could be congenital, but if it's surgical, it could be due to thick skin and abundant soft tissue, inaccurate approximation of the connective tissue, insufficient fixation to the tarsal plate, or low set fixation or loosening of fixation due to hematoma or edema. So how do we manage this? The management really is to create the adhesion between the anterior and posterior lamella to permanently anchor the dermis to the tarsus or levator. So we perform a blepharoplasty. It can be suture, mini incision, or upper blepharoplasty, which our previous speakers have talked about. So this is a patient with a faded crease, and we just did a suture blepharoplasty. Recovery is quite fast in general. Or we can do a mini incision blepharoplasty, which Alice talked about, but in my case, I prefer to anchor it to the tarsus and do that tau suture that Minjang talked about. So this patient had suture blepharoplasty twice by a plastic surgeon, faded, and then we did a mini incision for her. Even mini incision, the recovery is quite fast, even after week 1. You get quite natural results. Or you can do a full upper blepharoplasty. If it's a revision case, do note that you may want to fixate to the tarsus and do remove the excess pretarsal fat or connective tissue, especially at the medial side of the upper lid. And do note that Asian eyelids tend to have abundant pretarsal fat. So this patient had previous blepharoplasty but was unhappy with uneven eyelid height and faint creases. So we did a full blepharoplasty for her and with a bit of tau fixation. Depth of fold too deep, it could be caused by creases fixated too high on the lid, which I think Minjang talked about as well. So this places undue tension on the lower flap, then everts the eyelid margin and results in a depressed scar visible when the eye is closed. And if in severe cases, you get an ectropion, mucous membrane is exposed, the mucocutaneous junction becomes keratinized, you may get dry eye syndrome. So how do we manage it? We need to surgically open, release the adhesions, approximate layers at lower point along the lower lid. And if the ectropion is not resolved, you may need to undermine the lower flap, re-drape over the tarsal plate, and to decrease the everting force of adhesion on the lower flap. Next, moving on to crease height. A crease that's too low, if it's too low, it will show very little skin. I mean, it could be congenital, age-related, but if it's surgical, it's probably because the actual crease design originally was too low, or there's redundancy of skin that can make a crease lower than it actually is, or the levator is over-tightened, and this reduces the tarsal platform show. So how do we manage it? With an open blepharoplasty, the newer crease height is marked, the skin orbicularis is excised above the previous crease, and we create a mechanically overriding crease above the previous one. You can do this with a small incision blepharoplasty, and that's really inconspicuous scars from the first operation. So this patient had previous blepharoplasty, unhappy with asymmetrical eyelid creases and height, so this is a revision blepharoplasty where we raise the crease for her. Or the problem could be the crease is too high. It could be congenital, age-related when it's ptosis or sunken eyelid. Or if it's surgical, it's probably because of a high crease design originally, high fixation, excessive skin excision, or unintended adhesion. So management would be a revision blepharoplasty or ptosis surgery. So in revision blepharoplasty, the steps are pretty much the same, but I think what's important is the inferior skin and pretarsal orbicularis is dissected from the tarsal plate. The septum is open, that scar tissue is removed, and then that preoperative neurotic fat pad, a flap is lowered to the desired crease position and then sutured and secured with 7/0 nylon. So this patient wanted her crease lowered, and she wanted a very natural low crease, and so she underwent revision surgery. Or or you can just perform a ptosis surgery that really, if the high crease is due to ptosis, that addresses the high crease and ptosis as well. So moving on to pre-tarsal fullness, if it's too full, sometimes described as a sausage eyelid. So patients are actually referring to the unwanted soft tissue projection over the tarsal plate in post-blepharoplasty eyelids. So pre-op factors that can predict this would be if they have thick eyelid skin and an orbicularis muscle. Management will be revision blepharoplasty. You want to debulk the excess pre-tarsal tissue. You want to lower the crease, because when you reduce the height, you also reduce the volume. And of course, on the other hand, you can have a pretarsal that is too hollow. The causes would be aging, ptosis, orbital fat atrophy. Or if it's due to surgery, like I showed in the previous lecture, it's usually because of over-aggressive removal of tissue or post-anatomic socket. So the management, you can use filler, you can do ptosis surgery and revision surgery, repair aponeurotic fat or fat graft, or even with epidermis fat like I showed in the previous lecture. So for filler injections, there are a few ways to do it. You can walk the rim, fill the bone, and inject small aliquots of filler along the orbital rim, or you can inject it just beneath the brow and that superior sulcus using a cannula. And just be careful, because that's where the supraorbital and supratrochlear are, so it's a high-risk area, and you can get quite nice filling of the hollows if you do the filler injections properly. Last crease problem would be if there's no crease or multiple creases. So causes of multiple creases would be loss of volume, usually occurring above the natural pre-existing supratarsal fold. If it's surgical, like I mentioned in the previous lecture, it's because of overzealous tissue removal in the upper flap, and that creates adhesions. So if the crease is shallow, we can actually use filler or fat to bolster the skin, prevent further progression of the crease. But I think in most cases, like we talked about in that previous lecture, the open access is required. You need to meticulously release the adhesions between the levator and the septum, and between the orbicularis and the septum, and to prevent re-adhesion by inferior displacement of the septum and orbital fat. So if it's single, it could be congenital. If it's surgical, it's because of thick skin and abundant soft tissue, inaccurate approximation of connective tissue, insufficient fixation to tarsal plate, low set fixation, or loosening of fixation. So the management is very similar to what we described just now. You need to create a double fold through a blepharoplasty, whether it's suture, mini incision, or full incision. So now the rest of the lectures are actually just a summary of what we have been discussing. Eyelid height problems, if it's ptosis, may be due to several reasons. There could be pre-existing or latent ptosis. In East Asians, if the supratarsal fold is low or absent, mild ptosis may be hidden among the overhang skin, or it could really be iatrogenic from the blepharoplasty, where usually it occurs when you're opening the septum, especially in patients with very little retroseptal fat, and it can be prevented by having thorough appreciation of upper eyelid anatomy. Lid retraction, again, fortunately is not common after upper eyelid surgery, but this patient had previous ptosis surgery by another surgeon, and it's usually due to excessive skin excision or over-aggressive cautery of septum or levator, or over-plication of the levator, and so there's scarring and retraction. And of course, the risk factors would be if the patient had previous eyelid trauma, the dermatological conditions leading to tight skin and Graves' disease. So how do we prevent it? Careful measurements, and we talked about this in the previous lecture. Leave at least 10 to 15 millimeters of anterior lamella, and then of course be respectful of eyelid anatomy and avoid unnecessary manipulation or injury to the septum and the aponeurosis. If you want to repair it, you may require release of the retractors through levator recession, and like I mentioned in the previous lecture, even a skin graft, whether it's pre or post auricular or supraclavicular skin graft in severe cases of lag of thalamus. Ending soon, suture-related complications. I think there are a few advantages, like Vanessa described, but I think the main complication would be the disappearance, and I think this has been described before. If it disappears, you can just do a suture mini incision or full incision blepharoplasty. But I think a main problem with suture blepharoplasty is that it's a foreign material and its associated complications, especially with the tarsal fixation method. The sutures are passed through the tarsal plate, so potential complications include corneal irritation, discomfort, irritation, production of eye mucus. The conjunctival surface can lead to chronic inflammation, and several years after surgery, there can be sudden corneal irritation due to late onset suture extrusion. Also, you can see, if you see many patients with suture blepharoplasty, years later they develop these nodules on the eyelid skin. It may be from superficially located suture knot, where the buried sutures are visible as papules or chalazion-like granuloma. And in all cases, I think the treatment really is to remove the suture. And then related to eyelid surgery in general is beyond the scope of this talk, but we talked a bit about it in the previous lectures: hemorrhage, wound dehiscence, infection, dry eyes, the keratopathy, diplopia. So in summary, double eyelid surgery is a widely and commonly performed operation. While it's generally safe and successful in professional hands, the potential for complications exists because of the complex structure and function of the eyelids. So recognizing potential complications and understanding the basis of why they occur and how to manage are important tools for any surgeon performing double eyelid surgery on patients. Thank you, and we welcome you to Singapore in July. You can scan the QR code to register. Thanks. Are there any questions? Abby, we have time? Yes.
Thank you, everyone. I have a quick question from Dr. Alice. For that suture blepharoplasty, who are not the candidates? And for everyone, asymmetry of eyelid crease is very common. So I'm asking from all speakers, do you inject the Botox to suppress the eyebrow? Thank you.
Sorry. Can you repeat the question? The light is...
Sorry, the suture blepharoplasty, the mini blepharoplasty, who are not the candidates for this procedure? Thank you.
I think one of the reasons why I have converted from doing the suture to this mini incision is that it encompasses, basically you can do it in almost every patient, because you're able to debulk some fat. So in patients with puffy eyelids, you're able to also debulk a little bit. Like I said, if you from minimally invasive double eyelid, if you tuck in a bit more skin, it becomes menial. You can also address the eyelid holding as well. So to me, the ease of a simple procedure, quick recovery, I've actually incorporated, this minimally invasive surgery to almost every patient, whether they have excess skin or whether they want a double eyelid. You can actually apply the same principle with this procedure. So the question, because I used to do a lot of DST, but I find that when the swelling comes, when you develop swelling, it's really difficult for you to predict the height. So with minimally invasive, because there are two separate sutures, and because there's open, you can just if let's say, for example, if it's too high and the patient didn't like it, you can actually release the suture and then just bring it down a little bit. So with DST, the problem with the continuous suture is that once you suture it, because it's continuous, if you don't like it, you have to literally remove the whole thing and start all over again. So it becomes a little bit, to me, maybe a bit inconvenient. So that's why from suture to full incision back, then I eventually settled with the minimally invasive technique. But of course, your next question is that who are the patients who are not suitable? So unless patients say, look, I just want a full incision, I want a permanent solution to this, I don't want, there is the possibility of losing the crease. So I do have patients that refuse Minel, then I will do a full incision. And I also explain to them about the crease formation. So I believe, I think every surgeon has their preference. But over the years, I realized that, when you anchor the crease formation to the tarsus, at least in my hands, and I feel that, the formation of the crease, somehow you do get a little bit of depressed scar. Sometimes, even if you're not careful, if you do a full incision, if you anchor skin to levator, you can also cause a bit of depressed scar as well. So these days, I don't anchor skin levator, skin tarsus. If I need to, I will actually anchor form the crease through the orbicularis muscle. And then the surface of the skin, I will just do a continuous suture so that the surface, the approximation of the skin is smooth, is very, very smooth. And also, I do not remove pre-tarsal orbicularis anymore because I need to anchor, make the anchor to the muscle. That's why I leave the muscle alone. And also, I feel that if you remove the too much muscle, it actually causes a little bit of depression as well. So these are all very tedious nuances about creating a very, very good and very natural crease. And this is what patients expect, for you to perform these days in the current days, that where their expectation is very, very high.
Yes, Minja.
Yes, I showed pre-tarsal dissection and excision of pre-tarsal muscle. I always do that, but I'm very cautious to eliminate just, I want to a little bit let the skin, I remove it a little bit conservatively, yes.
Yeah.
So many patients have very puffy eyelid, and many Asians can have sausage-like appearance after blepharoplasty. So I think the pre-tarsal orbicularis muscle excision is needed for many patients. But and for the difference scar, I don't know, but many Korean patients, they like the more about the open when they open the eyes, not the close the appearance when they close the eyes. So that is not a big deal in my personal experience.
Well, I guess it's definitely a preference of the surgeon and also the demand of the patient as well. So if they say that, oh, I don't want to see anything, then this is something to put to take into consideration how you want to form the crease.
Thank you. Yeah. Any other questions? If not, we can close the session, and then maybe I invite the speakers to come to the front and take a photo.